Oh, okay. Evening, everybody. It's a great pleasure to bring you to the 2020 ANZ Virtual Venous Forum. This is something that we started last year at the Gold Coast, and we thought that we would be able to present again this year, but due to unforeseen circumstances, as you all know, we've had to change our format. And I hope over the next several little series, probably 4 or 5 sessions, that we're going to address several different parts of venous disease, and hopefully you gain a lot of knowledge and something that you can take away and use in your own clinical practice. Tonight we have Dr. Jonathan Langton, who is going to chair the session for us, and I hope that you're going to enjoy the talks and come back for the next session, which we'll discuss at the end of this one. So I'll take great pleasure in handing over to Dr. Jonathan Langton.
Thank you very much, Steve. I'm honoured to have been chosen this evening to be your host. My name is Dr. Jonathan Langton. I'm an interventional radiologist at the Sunshine Coast University Hospital in Queensland, and I have a special interest in the treatment of venous disease, vascular and lymphatic malformations. As your moderator tonight, I have been tasked with keeping things flowing. So without further delay, I would like to thank our sponsors, Bard and Phillips, for providing this virtual platform. And I'll take you through the running order and housekeeping before introducing our first speaker. So tonight we have 4 presentations planned. Logically, we will start with the pathophysiology of venous outflow obstruction, then instructions on the use of IVUS before moving on to May Thurner and non-thrombotic iliac vein lesions. The session will conclude tonight with stenting results coming to us all the way from Ireland. After each presentation, I will open question time. I would like to encourage you all to please type your questions in the Q&A tab on the bottom of your screens. If someone has already typed the question you would like to ask, then please like their question and it will be promoted to the top of the queue. Time permitting, the most popular audience questions will be answered, presented by me to the speaker. Don't worry if we don't get through all the questions tonight. Our panelists will endeavour to answer the questions and release them via email in the coming weeks. Now it is my pleasure to introduce our expert speakers this evening. From left to right, we have Associate Professor Laurencia Villabla from Wollongong, New South Wales, Dr. Gerry O'Sullivan from Ireland, Dr. Steve Dubenec from Sydney, and Dr. Phil Puckridge from South Australia. We will now move on to the first of tonight's presentations by Dr. Phil Puckridge on the pathophysiology of outflow obstruction. Dr. Puckridge has been a vascular surgeon for over 15 years. He is currently head of the vascular and endovascular surgical team at Flinders Medical Centre, Adelaide, South Australia. His special interest is in the management of venous disease and deep venous stenting. He also has interests in endovascular management of peripheral arterial disease, limb salvage, the diabetic foot, aortic disease, and dissection. Thank you. Over to you, Phil.
Thank you very much, Jonathan. Let me start sharing my screen and start my presentation. There we go. I hope you can all see that correctly. They'll correct me if we can't, that's for sure. I've been asked to speak tonight about the pathophysiology of venous outflow obstruction, which is a very interesting and in some ways difficult topic. We do know that our lower limb venous pressure, which we can measure with ambulatory venous pressure, is affected by our movement. Our normal AVP is around 90 millimeters of mercury. And as we exercise and move our limb and our calf muscles particularly, that will decrease over time, with after stopping of exercise, slowly return to a normal value. When it's pathological, that exercise pumping is less effective, and the rise back to a high pressure with even a baseline high pressure is much quicker. Chronic venous insufficiency is a consequence of venous hypertension that can occur in our lower limb. It's a failure of our outflow system, of the venous system. And it's caused by either valvular incompetence with reflux or in the veins, or venous obstruction, either through occlusion or stenosis. The transmission of that hydrostatic pressure through the venous system to the superficial tissues is what actually causes the pathological changes. And in a microcirculatory response, we see altered nutrient blood flow, tissue hypoxia to a degree, pericapillary fibrin cuff development, activation of leukocytes within the tissues of the leg, leukocyte trapping due to slow flow in the venous segments, and other molecular and cellular events seem to point to adaptive responses to injury as well as to abnormal healing. We classify this using our CEAP classification, which is, on a clinical point of view, looking at the leg itself from nothing, 0 being no visible changes, through to ulceration, with the spectrum of disease through varicose veins, edema, hyperpigmentation with hemosiderin deposition, development of fibrosis and sclerosis with lipodermatosclerosis or visible atrophy blanche, and then ulceration of the lower limb. And these, the edema through to ulceration is what we really are considering when we can consider chronic venous insufficiency and pathophysiological changes from venous outflow obstruction. We may also see varicose veins as a consequence of that, and that's where this issue can sometimes be quite confusing. Within the venous system, we need to understand its anatomy somewhat. Our hydrostatic pressure of our limb increases peripherally, and that's combated in the deep system and superficial systems by the presence of valves. We have maybe one valve in our common femoral. Normally we don't, but we could have one. But we have 2 to 4 in our femoral vein, 1 to 2 in our popliteal, and more valves in the deep veins of our calf where the pressure is higher. Superficially, we similarly have a terminal and subterminal valve at the top of the great saphenous vein, and 1 to 2 valves within the thigh, but more valves, 10 to 12, in the calf section of the great saphenous vein, as well as through the small saphenous vein. Valvular failure causing reflux can be a genetic predisposition or due to other factors, but secondary failure, which is what we're considering tonight, is due to a proximal cause of increased venous pressure. And that is due to an obstruction or occlusion from thrombosis or another cause. Our iliac veins don't have valves. They drain the legs through to the IVC and to the heart, but they are covered with overlying arterial structures. These create potential direct compressive forces on the veins. And this has not necessarily been as well understood in the past as maybe we should have understood. So venous outflow obstruction from compressive forces or from the occlusion of the iliac veins can occur secondary to deep vein thrombosis or congenital atresia. We can also have stenosis from venous remnants or webs, or from compression issues. And interaction between stenosis and thrombosis is part of the pathology here. Because, for example, May Turner's original cadaveric dissection showed that there was venous fibrosis and damage at the point of compression, as well as venous spur development. And acute endothelial dysfunction can occur in these veins due to stenosis because of the compressive forces. The combination of obstruction and reflux worsens venous hypertension and is associated with a higher proportion of signs and symptoms. Ulcers generally are more prevalent when we have reflux, and with a lower incidence when we have obstruction alone. But a treatment of obstruction allows decompression of the venous system and clinical improvement even when reflux is present. When we have llio-femoral DVT causing obstruction, the recanalization process is quite complex. It occurs through adhesion to the vessel wall, an inflammatory response, organization, subsequent contraction of the thrombus, neovascularization, and spontaneous lysis through areas within the thrombus. And complete lysis is quite uncommon. That process leaves a Synechiae filled fibrosed vein, sort of like a tunnel full of Spider-Man's webs. And you can see in this picture on the right-hand side of the screen, the obstructed vein in the iliac system with dilated tortuous collateral circulation trying to compensate. In the femoral vein, that damage, that recanalization, the adhesion of thrombus to the vessel wall includes the valves themselves, and the inflammatory process destroys them, leading to non-functional valves in this post-thrombotic limb. Acute obstruction of the vein also leads to distal dilation, and that by itself can lead to valvular failure of apposition and valvular failure. And when people talk about chronic thrombus within a DVT limb, they're actually really talking about scarring and Synechiae. It's a bad name for what we're looking at. Iliac vein compression, which causes obstruction or venous outflow obstruction, occurs at multiple points. Occurs behind the behind the right common iliac artery at the left common iliac vein, the so-called May-Turner point. But we generally call these now non-thrombotic iliac vein lesions or NIVL lesions. The left-hand side also has a distal point of compression behind the internal iliac artery where it bifurcates. And on the right-hand side, we have compression points behind the common iliac artery in the common iliac vein and at the bifurcation of the common iliac into the external and internal iliac arteries. We can also get compression at the inguinal ligaments as a final point of possible compression. So when we have those problems, we create a compressive force in the vein and a venous pressure. And that pressure will cause flow to follow the path of least resistance. This patient, for example, of mine, had a severe May-Turner type compression underneath the right common iliac artery. And we can see internal iliac vein reflux as a consequence of it, attempting to find another pathway for the venous hypertension. And seeing that reflux can often be quite pathognomonic. Alternatively, if we've got someone with a more distal stenosis, say for example in this patient, whereas in the external iliac vein, that compressive problem leading to venous hypertension must go somewhere. And in this case, that led to valvular dysfunction and reflux and incompetence through the superficial and deep systems. What was really interesting, and one of the things we don't well understand, is what happens when we treat this. And for example, with this gentleman, once we treated it, 12 months later, his deep venous incompetence had resolved and there was no longer a pressure effect on the deep vein. Finally, I want to talk about what is venous stenosis. Well, that's a very difficult question. It's not the same as arterial stenosis, and we shouldn't think of it as simplistically as we do in the arterial system. Arterial stenoses reduce flow. What happens with venous stenosis is very different. Do we worry about the area of the vein or the diameter? We need to remember that veins are capacitance vessels. They adapt to different flow rates and to different volumes of flow. And when we get fibrosis within that vein, maybe from various different pathologies, including compression pathologies, that prevents capacitance and prevents function. We have multiple compensatory mechanisms within the venous system, including lymphatic drainage, which can upregulate to fight against edema. But we need to remember that venous stenoses increase the pressure before the stenosis, and its compensation for that via the development of collaterals is dependent upon the radius of the collaterals. And it gets really difficult around the physics of this. Fluid dynamic physics doesn't really address the capacitance nature of veins well. The complex physics includes Darcy's laws, Ohm's laws, Bernoulli's principles. It's not necessarily all that well understood, but essentially our ability to collateralize these stenoses is generally inadequate. And I thought with that point, I'd come to an end of what I have to say and allow us to move on to the rest of the presentations this evening. Thank you very much.
Thank you very much, Dr. That was excellent. If I may, could I just ask, in your experience, what's a common clinical scenario which would raise alarm bells in your mind of venous obstruction?
That's a good question. I think these days, for me, anyone who has chronic venous insufficiency, where there's edema or skin changes, it's someone where I would consider investigating them for more proximal problems, venous outflow obstruction. In addition, when we do duplex ultrasound looking for lower limb problems, and we look at the lower limb venous anatomy, we often will see collateralization or incompetent flow coming from pelvis. And when we see those pelvic veins, it's a good indication that there may be something more proximal as a cause. And so if we have incompetent great saphenous vein, for example, but the saphenofemoral junction is competent, well, I think it should start raising alarm bells that something might be driving that. Now, the patient may not have pathology from that, but why are they getting something that doesn't fit that pattern? But certainly the chronic venous insufficiency, C3 onwards, absolutely, I think should be investigated.
Fantastic. Thank you very much, Phil. I'm just checking that we don't have a technical issue with our Q&A, but I think always a sign of good talk is that there are no questions to be asked. So I'll just
I'll say yes to that. I'm not sure.
But if there's not a problem with the communication between our audience, I think for the interest of time, we might either open up to the panel or move on to the next talk. What do you think, guys?
I thought it's very interesting, Phil, because when you see patients just with varicose veins, I mean, sometimes you get a patency incompetence study back and they've got deep venous insufficiency, and they really, you can't put your finger on why or how that's occurred, because they've just got great saphenous insufficiency or short saphenous with an incompetent saphenopopliteal junction, or even segmental popliteal. Do you think with that sort of scenario, even with collaterals coming from a pelvic source, you know, with the thigh and buttock tributaries that occur, do you think we should be looking more within the pelvis itself and doing a pelvic ultrasound?
Look, yeah, I think we should be looking in the pelvis. I mean, there's a lot of problems that we just don't understand. And for example, we just don't understand why we might have symptoms in the leg and even edema in the leg, but we might actually have no venous incompetence seen, but we might have a proximal occlusion. So we've got venous hypertension with a pathological consequence, but we can't see a valvular consequence. That's really confusing. We can have situations where we treat great saphenous vein incompetence, and then the person comes back with deep vein incompetence the next time you see them a year later, and it turns out that they've got proximal stenosis. And what the great saphenous vein incompetence is a decompression mechanism for the proximal stenosis that you don't realize is that cause. So there's lots of things which are very, very unknown in lots of ways around this, and what makes it quite fascinating to try to understand what's happening for an individual patient. I'm not sure that answers your question, Steve.
No, I think it does in a way. Oh, that was bad. Any other questions there?
We're now coming close to 20 minutes for this first session, so I think it would be a good time to move on to the next talk.
Thank you very much, Jonathan.
Thank you. Excellent talk. Thanks, Dr. Phil. Without further ado, Dr. Steve is a vascular surgeon based at the Royal Prince Alfred Hospital in Sydney and at the Mater Hospital. He not only has he been instrumental in the organization of this program tonight, but he's also put together a talk for us. He has been treating venous disease for many years and has been involved in a number of congresses and studies. He's he developed an interest in venous disease initially as no one else wanted to do it. But however, in doing so, he began to love it. So now we'd like to hear from Steve about IVUS and how to use and interpret it. Thank you.
Excellent. I'll just share my screen. PowerPoint. Can I just confirm that that's come up right?
I can see you.
Oh, it says it's failed to start. I don't understand that. Okay, I'll do it again. Share that. Then we'll click into that. Does that work?
That's the presentation mode.
Oh, okay. New share. What about that one?
It's not the slideshow.
Okay, I'll do it again. I think this should work.
Fantastic.
Okay, technical difficulties. Sorry about that. All right. Look, venous disease is extremely interesting. And over the years, I've found one of the tools that we have available to us is IVUS, intravascular ultrasound. IVUS is one of those tools that when you start using it and start to understand what you see on the screen, you want to use it more and more. The difference is between what you see on an image intensifier versus IVUS is that the image intensifier gives you a 2D image of the venogram that you're taking. And depending upon the angle of the image intensifier, you'll get a different degree of stenosis or flow through the lesion that you're trying to see. And we all know this from arterial pathology, but the same is from venous pathology. But it's a little bit harder to see this by angulating the II with for venous disease, I think, than it is for the arterial disease. They're bigger vessels, they're within the pelvis, and sometimes they just don't show up very well. Intravascular ultrasound is something that we can use. You can see this is a venogram in an AP, and this is just an RAO view of about 50 degrees. It shows a very different picture. They're the same vessel, the same lesion, but it shows a hold up of the contrast around that May-Thurner syndrome, that the May-Thurner point that we can treat if necessary. This is an IVUS picture. Now, the difference between IVUS and venography is that you get a transverse picture, and you can do pullback live images within the vessel, identifying areas of compression, degrees of stenosis. You can calculate a whole lot of other things, which I'm going to show you in a minute. The new Core M2 by Philips is a Volcano system. That's what we use at RPA and at the Mater Hospital. And I'm very happy with what it tells me. And as you get comfortable with a particular sort of image system, you'll get to know all the little intricacies. It shows a transverse image of the vessel itself. It can then go on and show you diameters and areas, which you can calculate based on those images. And you can do a live pullback and reference that with the actual X-ray image side by side if you have the right system. Now, in saying that, the image is not what you get is not all you get. You can actually adjust the image with the gain, the diameter of the view, the diameter of the probe, rotation, and depending upon the type of catheter that you use, there's other functions like chroma flow, where you can see flow within the vessel for an 018 or 014 system, and even ring down, which can take away the catheter itself from the image. These are just examples. This is the gain on the left-hand side and the diameters that can change. You can, on the 035 system, you can go up to about 10 centimeters in diameter, 5 centimeters each side. The gain, it's just like a glorified ultrasound machine, which we all use every single day. the right-hand image just shows you a luminal diameter representation as you pull the catheter back within the vessel itself. And that can show you a longitudinal image if you do it constantly at a set rate. You can get an idea of the degree, the length of stenosis of the vessel. And it just takes practice. The freeze frame images that you can take, you can then stop and you can work out areas within the vessel, changes in areas, you can maximum, minimum diameters. And these are all very important when you're trying to work out whether or not there's a significant stenosis or you're trying to size up for a stent when treating somebody. As Phil's already shown you, the typical areas of stenosis within the NIVL system and the iliac veins of the Matherna, the right, where the right common iliac vein artery crosses the right common iliac vein, the internal iliac arteries crossing the veins at both bifurcations of the iliac vessels itself. And this is a pullback coming from the IVC all the way back, showing as the right common iliac artery crosses the left common iliac vein, Matherna there, giving significant compression. You can change, you'll see areas of shadowing, which you can change the gain and you can get rid of, and you can rotate the catheter. Sometimes there's just a little bit of gas or something which will make it difficult to view the picture, but changing the catheter and moving it backwards and forwards at times can adjust that image. But importantly here, you can also see that there's a significant stenosis as this internal iliac artery crosses the iliac vein, causing another degree area of stenosis. Now, not only does it identify stenoses, it will show you occlusions. This is a pullback coming from the IJV approach, coming from the common femoral vein all the way back, common femoral and external iliac. There we lose the lumen, we have some shadowing, we've got a large external iliac vein which becomes patent again. And then as we more proximally towards the heart, we have more occlusion and a big collateral that's coming off and bypassing that area of occlusion and then feeding back into the common iliac vein, more proximal just as it enters and becomes a confluence of the IVC. So once you can sort of get an image and put that image and reference it with a venogram, you get a really good idea of what's happening inside the vessel, where the collaterals are coming off, the significant stenoses and occlusions, and then you can plan your intervention and treating a vein from a good section to a good section and not landing your stent halfway in an occluded vessel, which will impede your result down the track. IVUS is extremely important. And I don't know how I did venous interventions before I was using IVUS. The positioning of stents is very important. This is, you can see on the left-hand side, I've got the image intensifier, just pulling backwards and forwards across where that common iliac artery is compressing the common iliac vein in the Matherna spot. And we all know if we land that stent a little bit too short, we can end up with the common iliac artery rolling across the top of the stent and causing a more proximal narrowing. And we end up having to place another stent anyway. By using IVUS, you can identify where that compression is, where that artery is going to stop, and place your stent against a bony reference point and are more likely to get a successful result from your intervention. With IVUS, we can calculate cross-sectional areas and diameters, and this is just something I pulled out of phlebology back in 2018. These are the types of cross-sectional areas that we should be hoping to get within the common iliac vein, about 200 millimeters squared, which would equate to about a 16 millimeter to an 18 millimeter stent, external iliac vein 14 to 16 millimeter stent, and a common femoral vein 12 to 14 millimeters. All of these flow and these areas are indicative of a decent sized vessel, which is not obstructing to flow. This is an example of a significant stenosis. Pre-stent, the vein is actually almost shut down, and that is the right common iliac artery just to the right of the green line. I'm sure it extends out a little bit further, but I couldn't take it any further with any confidence. And so I've just put it there just for the image. And we see that there's extensive left iliac vein stenosis further down in the vessel. Now, what that equates to, that IVUS image, if you do a 3D venogram and you see this is should be an occluded common iliac vein at the May-Thurnes point. That vessel is almost occluded by compression of the right common iliac artery against the vertebral body. Also, we have the left common iliac artery, which is compressing the iliac vein, and you can see the indentation just through here, down to the confluence of the internal iliac and the external iliac veins. And this gives you an excellent idea about where we should be stenting from. We need to start the stent beyond this compression, and we should be ending our stent somewhere down here in a straight segment of vein to get the best result. Post-stenting, we can see our result with the IVUS itself, and we can calculate the area post-stenting. This was 187 millimeters squared, so an acceptable result. And the external iliac vein post-stent, again, decent area. We can identify the effects of treatment, and this is important because this is a stent I placed in a young girl many years back, probably about 5 years ago. She's young, she had significant loin pain, she had leg swelling, leg pain. She had a typical May-Thurnes syndrome, but she also was young, had a nutcracker, an incompetent, very large ovarian vein. So she was basically shunting the blood from her left kidney down the ovarian vein into the pelvis, and she still had significant compression from her May-Thurnes syndrome. So at the time I used a stent, which I thought was going to be good, and we left it for several years, but she had ongoing pain. And only when I had the use of the IVUS did I decide to say, okay, let's go back and we'll take a look at this with an IVUS. Now, when we pulled it back, we got an area of cross-sectional area of 82 millimeters squared, which is nothing for a common iliac vein. You can see on this that the venogram that I did probably about a year or so previously probably looked all right because I was taking an AP and a slight angle. So there was enough contrast going through that slither in a perpendicular perspective. So it looked actually that it was patent, but if you look at it from a transverse perspective, it wasn't. So after angioplasty, still didn't work. And after a stent with the Venovo, we now have an area, cross-sectional area of 208 millimeters squared, which is really good. Now, coincidentally, I actually just saw this young lass today. She's now in her early 30s and thinking about children, but she has no leg swelling. She's extremely happy with the result. And I don't think I would have picked this up unless I used IVUS. Stent apposition is important. We need to size our stents appropriately. And sometimes if we undersize it, we will see this. Now, in an iliac system, if this was just from a segment, this would be acceptable. But if it was in the entire length of the vein and you didn't get good wall apposition, you'd worry about stent migration, and you probably have to do something about that at the time. So a post-procedural or post-IVUS is extremely important to show you how effective your treatment is. So in conclusion, if you're treating somebody, IVUS contributes greatly to venous interventions and interpretation. And I really, truly believe that if you're doing any venous interventions, that we should be using IVUS routinely. If you're not doing that, you're missing a lot of information. And I think you'd be surprised at what you're actually doing. And the other thing is that regular use of this system will improve your interpretation and the results that you're going to get with your patients. Thank you.
Thank you very much for that, Steve. Myself, as someone new to IVUS, one thing that I've really appreciated with the system is its ability to reduce the radiation dose on young patients. Although I'm new to it, I've been very pleased with the chance we've had to use it up on the Sunshine Coast. And as being new to it, I'm keen to learn from you, what are the characteristics that you look for when using the IVUS to pick your stent landing and to pick the stent landing zones? And are there any traps for young players?
That's a great question, because it's difficult. I think it's very important to use IVUS with a bony reference. And you could see from the images that I showed you that I had a fluoroscopy image lined up on the screen next to the IVUS. Now you can do this with the IVUS system sitting next to your screen, but so long as you have both of them in proximity to each other, when you're passing the IVUS catheter through the lesion, you can actually reference that against bony landmarks. Now, with treating a NIVL such as a May-Thurner syndrome, you really want to know whereabouts that common iliac artery is crossing the common iliac vein and causing the compression. You have to cross and place the stent underneath it, slightly beyond it. If you don't do that and you place it halfway across the crop, you will end up rolling the artery over the top and causing another stenosis just more proximally towards the heart. The other thing is that you can see from some of those images that you do get other areas of compression. And unless you're using the IVUS, you won't see them that well. Like the confluence of the internal and external iliac veins is a very common area for another stenosis. When you see that, you can actually think about where you're going to land the stent. You probably don't want to land your stent in the curvature of in the pelvis. You want to extend it through that curvature and land it where the external iliac vein is actually fairly straight. So you don't have stents overlapping in that zone either. That way, if you do have that compression, you're going to go through that compression, treat that compression of the iliac confluence, and land it in a straight segment. I think that's what I do personally. I find it very helpful using those bony landmarks to help you place your stents. Does that help?
Thank you very much. I'd now like to direct you to a question from the audience. How far into the IVC are you comfortable extending a stent? And can you cover the right common iliac vein when treating May-Thurners?
Look, I do extend the stent, and I extend the stent into the IVC, covering the origin or the confluence of the right as well. And I can actually show you some images where I've placed a catheter over through and into the right side. And the stent cell structure is big enough that it doesn't obstruct flow. Again, I think you need to treat that lesion, and sometimes you'll end up putting the stent across so that you're placing the angle of the stent will actually touch the opposite wall of the IVC. And I don't think there's a lot you can do with that with some of the stents that are out there. The oblique stent said that you possibly could do that without covering the other side. I haven't used that a lot. Maybe Gerry could answer that down the track, but I don't think that's a real issue in my book about covering the other side.
Okay. And another question. Sorry.
What's that, Gerry?
Can I come in on that one?
Yeah.
Okay. Sorry for being delayed for a start. I have difficulty with time in my own country, never mind trying to figure out what's going on in yours. So the contralateral, covering the contralateral side is a bit of an issue for me. I think with large aperture cells, covering it is less of an issue, but there's a fair bit of data out there now from Erin Murphy from Raju's, or was in Raju's group, from Olivier Hartung and myself. We published from Galway, and there's a fellow in the States whose name escapes me right now. Anyway, the rate of contralateral iliac vein thrombosis is somewhere between 3 and 8%, depending on what stent you use and how much coverage when you cover. So if that's your confluence like that, I wonder will my fingers even work. With the modern stents, you can get it so you don't have to land like way up like that, but you can just cover. And I agree with Stephen's idea that you can have a catheter from above. It's a fairly simple way to do it. If you have, say, a 10 French teeth here, you put it down 2 5 French catheters and do a venogram. You can identify the confluence really easily. But in addition, you can precisely estimate where to land the stent. And in my view, if you look at the say L4 pedicle, you've got spinous process and pedicle. And if you get it dead straight on, so that the the spinous process is directly in between the two pedicles, you then can land your stent midway between the spinous process and the pedicle and not cover the other side. Anyway, there's other ways to do it. IVUS is more accurate again, but not everybody has IVUS. But I would try and avoid it. But I think Stephen's major point is right, that you must treat the initial lesion. I think we've all got caught on lesions where you tried to be too clever and you decided, oh, I'll just have it. And then with the wall stent particularly, it can shorten back and then uncover the primary lesion, a whole lot of rethrombosis, and then you feel like a right plonker.
Do you think that the rethrombosis for the other side is very different because there's a lot of people still using the wall stent and the closed cell stents, whereas here in Australia, we have the open cell structure.
Yeah,
and that's a very different stent.
It is. I agree. And I think it's hard to know. I mean, the way Raju and Neglan described it initially, they had the stents kind of halfway up towards the renal veins. You know, they were making absolutely certain they covered the lesion. And for years, Raju said there was no incidence of contralateral thrombosis, but eventually Peter Glavici got him to really go through the data, and Aaron Murphy showed it at around 10%. So what they did then was they changed the top end to being the Gian Turco Z stent. Now, it's a very old stent from Cook, and it has good radial force and very little metal, but it's a pain in the ass to use. And so as in Australia, you know, you've got access to Sinus Obliquus and Medtronic Abra and Bard Venovo and Cook's Vena and so on and so forth, Veneti Vici. And those are all stents with relatively wide apertures. So it may not be as much of an issue.
Can I jump in as well, Steve?
Oh, yeah.
You mentioned using IVUS, and I have to admit that that's become part of my standard practice for this, is that I park the IVUS in the right common iliac vein confluence to IVC and literally watch the stent unfold and I can see how far it's coming across to the wall of the lateral wall, and I can adjust it. And so that's become very much part of how I deploy this stent. Is that become a very standard practice. I've got the IVUS, I just plunk it in the other side, and we have a look. And as Gerry said, you can come from the neck, you can come from the other femoral. It probably doesn't matter so much, but it gives me live view on exactly how far that's coming across as we're doing it. And you mentioned you've got some pictures of the same. I just think it's a good technique. We should probably mention it.
Good idea.
So you're placing 9 French sheaths in both groins, or doing that from the neck and the groin?
I place an 8 on the other side because it just needs the IVUS. And it's a venous puncture and low morbidity from that. So I haven't had an issue from that perspective. But coming from the neck keeps you completely away from the groin, of course.
Yeah, that's a good point, because the venous punctures are very low pressure. You don't get a lot of bleeding, and just to be careful, that's a good way to play it.
I like that, because normally what I do is I've been using, if I'm doing one side, I'm doing more and more of my work from the neck. The big advantage is you can get the patient up immediately. I've had a couple of patients in whom I've punctured a diseased femoral, and then in compressing afterwards, I've thrombosed the whole damn thing. And I thought, oh, I don't want to get caught with that again. So I've gone more and more to the neck. But the one disadvantage is you can put in 2 10 French sheaths, which are fine. I once tried to go from both necks. That's a disaster, because the patient couldn't decide which side to turn their head, and I looked like a turkey going around from one side to the other. Idiot proof. Don't do it. So stay on one side, and 2 10 French sheaths here is not a big deal. I mean, you sit the patient up at 45 degrees and you're having your coffee pressing. It's not a big deal. It's not like arterial. But I like the idea of actually having the IVUS in the opposite side, so you get, I mean, really precise measurement, because there's a paper out just by Raju just recently talking about IVUS and venography, and essentially how inaccurate venography is in terms of determining the actual confluence, as opposed to where we think the confluence is by venography. And IVUS would give you a very precise estimation of that. So it would be a nice technique. And again, 2 10 French sheaths in the neck is not a problem. So that's a really good idea, Philip. I might try that.
Thank you very much.
Gerry,
sorry to interject.
You might know this is the PI of the vernacular study.
Probably not.
Probably not. But I haven't seen very much about contralateral venous thrombosis with placing stents for common iliac lesions.
So
I'm not asking you to give me the data. It's only if you know it.
Oh, I see. Well, interestingly, actually, in the FDA trials, in the vernacular trial, and I can't remember the ABRA, I think the ABRA was the same, you had to demonstrate, on follow-up this is, you had to demonstrate a contralateral common femoral venous waveform. Now, we've all seen that you can have a relatively normal common femoral venous waveform and yet have thrombosis or stenosis above it. So I know that, say, in the contralateral paper that I wrote with Olivier Hartung from Marseille, who's ridiculously honest, and you know, he's so French, he's there, we had a disaster, the patient died, you know, it was very sad, you know, and there's no glossing over it at all. Like, it's not like an American thing where it's like, you know, they're trying to sell it. He's just like, it's very sad, you know. But anyway, he's very honest, and so I really like working with somebody like that, because you get the data, it's like, here it is, you know, you can do whatever you want with it, but this is it. So he had a rate of around, I think it was around 3% in terms of contralateral thrombosis. We were much higher in Galway, we were about 10%. And that's probably because I'm fairly crap, which is logical, but also because I work with a lot of cancer patients, and finally because I do CTV follow-up. So in CTV follow-up, you're going to find more patients. You're just going to find. Now, a lot of them are asymptomatic, but the rate of contralateral thrombosis in the Galway group was at nearly 10%, I think, in the cancer group. Olivier was around 3%. The Raju and Neglan paper got up towards 10% using the wall stent alone. But to come back to your original question, in the FDA trials, they didn't actually ask us to check. So again, it's a bit of a blanket space in the knowledge, you know, and because we were doing ultrasound follow-up of one ultrasound follow-up of the entire length of the stent on the stented side, but only the contralateral common femoral venous waveform, you could potentially have certainly missed a contralateral common iliac vein thrombosis, and sometimes they're not particularly symptomatic, which is hard to believe, but you know, it can occur. So I'd say the data it's less than 10%, above 1%, but probably at a level that one should mention it to patients, which is, I didn't until until I saw that actually, yeah, this is real, because I mean, we all mention risk of at 1% level for most things, you know, but I'd always thought contralateral common iliac vein thrombosis was very rare until I looked at our own numbers and it was like, wow, 10%, that's that's not so rare.
Thank you very much there, Steve. Sorry, thank you, Gerry, for that. And thank you, Steve. I've been monitoring you and seeing you've been answering questions on the fly. So because I was conscious that I'm supposed to be giving the audience a voice. Is there anything else anybody would like to add before we move on to the next talk?
We can answer Toby Richards's question at the end, I think, if it might be more beneficial.
Yes.
Okay.
We should move on.
Who's next talk? No, John.
Now I'd like to introduce Associate Professor of Vascular Surgery at the University and Head of Vascular Surgery at Wollongong Hospital, Laurencia Villabla. She studied medicine in Argentina and then began her vascular training in Canada. She completed a fellowship at the RPA in Sydney, where her skills were recognized, and she was persuaded to remain in Australia. She is a supervisor of training, an examiner, and a founder of several vascular services in and around Wollongong. Over to you, Laurencia.
Thank you very much. It's a pleasure to be here today. I'm very grateful to have been invited and to feel that I'm amongst friends. So thank you very much for that. Today, I've been asked to talk about NIVL lesions and how I see it. And already it's been made easy by my colleagues in explaining what we're looking at and why we should be doing this and who should be treating Phil made a very, very clear explanation of why obstruction is significant. And when I first started doing this, I went back to the book, and suddenly I realized that, hey, hold on a second, in our TIA work, we always look at the oroiliac system. Why are we not looking at the proximal veins when they're connected to the legs and they're connected to the pelvic organs? I did a little bit of refresher in anatomy, and found out all these names that obviously we don't remember when we're looking at these patients. But when you go back and examine the patients, then all these things make sense. One person that I admire a lot, Mark Meisner from the States, talks about how there are 4 escape points in the pelvis. So when we have obstruction, that increased venous pressure has to go somewhere. Like Phil said, it has to find a path of least resistance. And sometimes that goes through these pathways, goes through these points.
Dr. Laurencia, can you please share the presentation, because it's not shared on the screen? Can you try reshare this, the presentation, please?
I'll go back.
It's a pleasure looking at you, Laurencia. So you can just keep talking. Nobody's really too stressed, you know. We had actually forgotten that your presentation wasn't on at all. We're just like, oh, sorry. I mean, in a professional manner, obviously.
Can you see now?
It's better, but you're much smaller, so I'm not so sure if I'm happy with this trade. Can we go somewhere in between?
Sorry about that. Anyways,
go to
okay.
Yeah.
So we'll go through all that. So you know the anatomy, you know the pathophysiology. These are the points I was talking about. So how, depending on the pathway that the veins choose, is what kind of things we can see in the patient, and all those things that Steve was talking about. When you see patients with varicose veins in the gluteal area, or in the round ligament, or even in the GSV, like Phil said, and sometimes can be coming from a pelvic source. Again, this is a very good diagram to show us what happens when we have obstruction. And this explains why these patients do not improve with exercise. They not improve with compression, and it's because they cannot drop that pressure the same way that people that are normal or people that just have incompetence can do. So what is the evidence? Well, the first thing I'm going to say is that this is not new. And we have the pleasure to be with Gerry today. Gerry has been writing about this for however long. And when I started doing this, I thought that I was so smart and I figured out all these things. And then I went back to the book, and it's all written. It's all written. It's been written for a long time. And there's a multitude of case series with a very long follow-up with consistent results and a consistent message. And multiple society guidelines recommend an intervention for symptomatic patients, including ones that Gerry himself has written for the series. But as you all know, it's only been the last decade that industry and the medical community have got a particular interest in this, and I think that's why it's growing. Now, what we're lacking is robust hemodynamic criteria to identify which patients would benefit from intervention. We're lacking randomized controlled trials comparing conservative management versus intervention, although there's one coming hopefully from Europe sometime soon. And we don't have a tool that helps us with good patient selection. It's a little bit of an art and experience. So I'm just going to share a few cases that made me think about pelvic obstruction, and hopefully you might resonate with some patients. Some of these cases are very embarrassing because it took me a long time to recognize. But anyways, I'm just sharing my journey. So this is a patient of mine that I saw in 2010. That's my letter so that you can see I'm not lying. Had an ulcer that had been present for 2 years. He had had ulcers for 30 years on and off, only a few months in between of a heel ulcer. He was 80 at the time. He had had bilateral stripping, and very soon after he developed an ulcer, normal ABIs, and widespread deep incompetence and some segmental superficial incompetence. So of course, what do I tell this patient and his wife? To wear compression continuously forever. And I am very proud of my advice because, oh my God, this is obviously why this hasn't worked. This patient has not been compliant and has not listened to the advice. He just needs to stick to the compression. This poor man continues on, and a few years later, the ulcer is still there. We repeat the ultrasound, and now we find some disease in the SFA, some disease in the tibials, ABIs are a little bit depressed. So, of course, what do? We offer him a balloon angioplasty to improve the ABI so he can continue compression bandaging. Off he goes. We feel very proud of ourselves. 2 years later, comes back again. You can see the leg there, very swollen, looking terrible. A little bit of recurrent stenosis. Very proud of what we can offer. Oh, let's do a drug-eluting balloon now. See, we have the latest of the latest. 7 years later, so this took me 7 years. The wife calls me crying, very distressed, telling me that the community nurses have suggested that she puts the patient on palliative care because they can't cope anymore with this. And she doesn't know what to do herself, and asking me, please admit him to hospital so I can have at least a day or two to think about this and what am I going to do. So I plan to do an angiogram again and a debridement. And then I have this aha moment, and I'm thinking, holy, I have never, ever looked at the pelvic veins. I haven't even thought about it because I wasn't, really looking into that. So I do an angiogram, which of course shows nothing. And then I do a venogram. And I go, oh, is there anything there? Oh, I don't know. If I only had IVUS, which I didn't at the time. And then I did this cheap IVUS technique, which I did for a while till I got IVUS, which was a balloon inflation technique. So looked at something, I think there's something there, put a balloon, and surprise, surprise, severe stenosis on the balloon wasting. I had to reballoon, end up stenting. You can see there's another stenosis below that. What happens? Despite our very primitive efforts and despite not having IVUS, within 12 months, the ulcers started to heal and heal and heal and heal. 12 months later, that's what it looked like. Today, that's what he looks like. So I can't tell you how stupid I felt having made these patients suffer for 7 years. And finally, at 87, he healed his legs that he had had for 30 years. So remember that one? Another one, very similar, so same but different patient that I had been looking after for 10 years with arterial problems, popliteal aneurysm, and of course, chronic venous disease, but deep incompetence on the variant. So the speech was, there's nothing we can do about it. Sorry about that, but compression for life. And again, had problems in the pelvic veins. This is a patient that one of our renowned phlebologists sent me, a very smart phleboligist in Sydney, who had been treating this patient again for a decade. Every single vein had been ablated or injected or something done to it. And that ulcer could not be healed for more than a couple months at a time. And then when he found out that I was using IVUS, he said to me, oh, do you mind having a look? Because I don't have IVUS. I've done a venogram. I'm not sure there's something there, but please have a look. And again, surprise, surprise, we found a Materna, fixed it, and oh, there you go. No more ulcers, no more injections. So we all know then that ulcers, we have to look at patients that come with ulcers. There's no discussion. Always look for pelvic obstruction because you will find more often than not. But what else matters? What other problems do we have? I do have an issue with the CEAP classification. I think it doesn't really include a lot of the symptoms that the patients get, and we need to, devise a better system to look at these patients. But this is a typical one. You can see the difference there in the leg. You can go, oh yeah, look at that difference. But the main thing that these patients complain about is not the swelling, it's the pain. They have pain with the swelling. And this poor woman, she was a triathlon runner, and then she couldn't stand. She couldn't stand for more than 10 minutes with stockings and an extra garment on top of that. So that's what bothers the patients. Now, another one that again was a surprising thing for me is a patient that she was in her 30s, and in 2015, she went to see a vascular surgeon because she had this long history of blue feet. She had purple feet, and she could walk normal at a moderate pace, but whenever she was walking fast or was going uphill, she had pain in the thighs and the buttocks, and she had been having these multiple syncopal episodes since she was a teenager. Multiple investigations, you can imagine, MRI, CTs, arterial scans, you name it. The vascular surgeon that saw the patient told her to go see a psychologist. There was nothing wrong with her. There was not ischemia, go away. Year later, sees another vascular surgeon, same speech, you're depressed. There's nothing wrong with you. She is put on antidepressants and anxiety medication. In 2017, the GP sends it to me because the GFR is 79, and he thinks that she might have a nutcracker because when she was pregnant, her urine was brown. And sends it for a scan that shows that she has a Mather. On questioning, she has chronic pelvic pain, she has leg pain, she has edema, she's had vulvar varices, and she has a very typical venous claudication. Needless to say, when we fixed her, no more antidepressants. Now, this is something that I find very difficult in terms of decision making, but mostly because the patients are very young. But 20-year-old, this is the referral from the GP, very clever GP, says severe pelvic pain for the last 2 years, no varicose veins, but has abdominal veins, which is something that I only learned from Rick DeGraff recently, like in the last few years. So very surprised that the GP picked up on that. And the GP gets her to have an ultrasound, and there's some IVC, stenosis, compression, whatever it is. And then you can see the venogram here, that common event is pretty much inexistent. And you can see the iliolumbar collaterals that can explain that back pain and so on and so forth. And when talking to this patient, and explaining how difficult it is to make a decision, and she's so young and blah, 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 she says to me, so you're telling me that I am too young to have this fixed. You want me to continue to suffer? I can't have sex, I can't have a boyfriend, I can't work, I can't study, I can't, and it's okay for me to do that. And when am I going to be old enough for me to stop suffering? So it's a very difficult ethical discussion, and I'm sure you all struggle with that one. So how to work these patients up? Well, like I said, it's very difficult, but what I've learned is that imaging is just an adjunctive. Imaging is when you've decided that these patients need something. You can find a variety of symptomatology with the same picture. So I think the clinical assessment is the most important. Listen to the patient. Use adjunctive assessment tools like whatever PCCS, or I use actually the visual scale for pain. I find that pain is one of the most important symptoms and one of the most dramatic improvements you can find by treating these patients. And the one thing that I've come up with is that, like any vascular pain, it has to be reproducible to be believable, and it has to be obviously related to gravity and related to the amount of blood in the system. And if you can reproduce the pain, probably you're on the right path. Now, the question of million-dollar question, do we need IVUS? Well, when I first started, and then I got across IVUS, I thought, I don't need IVUS, this is just a gimmick. And I know what I'm looking at, and I've read everything that Gerry has written about how to identify the points and where is the bifurcation and all of these things. So do I really need IVUS to make a diagnosis, to decide when to stent, what size to stent, where to put it? To assess expansion, I can do a cone beam CT. There's all these things that I learned and from all these other people. But I'm just going to remind you of something. IVUS planimetry is the only measure that has been proven to predict clinical outcomes. So it's the only thing that we know for a fact that can be correlated to clinical outcomes. So we have to respect that. And these are some of my initial experiences with IVUS. I did a venogram in this patient with significant symptoms, and you can see that there's nothing there. Then you see multi-view venography and you go, oh, maybe there is something there, but how do you quantify that? What does it mean? And you do the venogram and you go, oh yeah, well, they're collaterals, definitely, probably something there, but it's only till you do IVUS that you really understand how bad it is and exactly what it is. And it's surprising how often it's not what you think it is. And in this patient, it starts in the IVC. There's problems in the IVC. And then there's problems in the common iliac. So it gives you a lot of information that, like Steve said, the more you use, the more it helps you understand the pathology. Now, we have to be careful not to overcall things. This is a patient that when I first saw him, I thought, oh, for sure, this is pelvic obstruction. I did a venogram. The contrast would not go into the IVC. I could not for the life of me get contrast to go into the IVC. So I thought, for sure, this is something. But I had IVUS, so I thought, okay, let's put IVUS. I'm bringing the IVUS back and I'm pulling back and whew, suddenly there's this narrowing. And I turn around to tell my registrar, see, look at this. Look, it's terrible. 2 seconds later, the patient takes a breath and look at that vein. Now it's open. So what happened was this patient is so big that his abdominal wall compresses the IVC completely when he's breathing. And then when he takes breath and expands and collapses and expands and collapses. So instead of putting a stent, I sent him to have a lap bending, obviously. And there you go, fixed, right? Now this one is real. And this is what I do now routinely. If I see an area that I think is compressed, of course you see all that white stuff that is the scar on the vein, which is what we're treating really. We're not treating compression, we're treating the stenosis that is a consequence of the compression. And then if you get the patient to do a Valsalva, then you can see if it's real, it's not gonna move much. It's not gonna expand, it's not gonna, it's gonna stay static. And then it's also useful to do it on the healthy vein, so you see how big that can get if the patient is very well hydrated or so on and so forth. Again, it helps with positioning, definitely helps with positioning. This is a patient that, like Steve said, was stented too low, and then the artery just compressed that stent, and the patient had back pain for 2 years after the stent till I saw her. And then I remember I called Steve Black saying, is this possible, back pain because of a compressed stent? And he's like, yeah, fix it. And sure enough, fixed it and the pain went away. We want to see stents nice and round, but more often than not, under the compression side, they don't get as round as we would like, even if you post-balloon them aggressively. In any case, in conclusion, I can tell you that NIVL lesions can cause a variety of symptoms and symptom severity, and we still don't know why some people are bedbound in pain and some people are walking around like there's nothing. But clinical assessment, I think, is paramount in just listening to the patient. None of the available assessment tools are complete. You can use several of them. One of my tricks is to send the patient away, and then if they come back, it's usually real. And I think IVUS use is non-negotiable. If you're going to do this, you need to use IVUS. Thank you very much.
Thank you very much, Laurencia. That was excellent. Thank you for sharing those cases and also touching on how veins are a dynamic structure within the body responding to Valsalva maneuver or hydration status. And commonly when we get people on the table, they are fasted and underfilled. But I can also point out that you've got a number of fans in the audience on the Q&A. Having treated a few young patients with May-Thurner syndrome, how do you go about preparing them for, because I've noticed in some of my patients, they've got good relief of the leg symptoms, but have you noticed that stenting, especially behind the artery there, causes them any immediate post-op discomfort? And what kind of follow-up and treatment do you give them in terms of anticoagulation once you have stented them?
Yeah, so I counsel them extensively, and I never intervene quickly. I actually put them on a 12-month waiting list purposely, even after I see them several times, and I make them go away, do pain diaries for a good 6 weeks. And anyway, so I do have a protocol to really sort out the ones that are real, because there's a lot of patients that it is very hard to tell, and like I said, the symptoms are not specific, right? So we have to be careful with that, and we have to, obviously the ulcer patients are easy, but the other symptoms are not so easy. So I do that, and then I counsel them extensively. I tell them they're all going to have back pain. In my experience and the experience of others that have done way more than me, back pain is usually related to oversizing of the stents. If you stick to small sizes, 14 or 16, then the back pain is not that bad and self-limited within days. So usually the first night we'll have back pain, and it's like a muscle spasm, and then by day 2, day 3 it goes away. I only have one patient that had extreme back pain for 2 weeks, bedbound, and it was actually a sinus obliquus. So I don't use it anymore, but it's a very, very strong stent. And it's difficult to deploy. And like I said, this patient was not very fond of me for 2 weeks. So I think if we stick to smaller sizes, which is what most experienced people are doing all over the world, I think you can avoid that problem. I also put them all on anticoagulation, and again, that is something I learned from Rick DeGraff and Stephen Black. Very aggressive anticoagulation. When I first started, I was only putting them on aspirin and Plavix for 4 weeks. And when Rick told me, oh no, I put them all on warfarin, I was like, really? That's overkill. Like I don't have any problems, till of course I had one problem, and I had to bring the patient back for an angiojet, and suddenly I realized that in some patients you get these implantation problem, post-implantation syndrome, and an acute thrombus. So I use it also as a deterrent. So I tell patients, you're going to have to be on Clexane for 4 weeks, on warfarin for 6 months, and on aspirin forever. And again, the true patients, the ones that are really symptomatic and they want this, they commit to that. The ones that just want a quick fix, they go away. No, I'm not doing that. So it's a bit of a trick to select patients. But since I started doing that, I have not had any problems with in-stent thrombus. So the patency rate is incredibly good.
Fantastic. Thank you.
Can I ask, Laurencia, with this, the inner stents, I was going to pitch a question to both you and Gerry later on, but by inner stent thrombus, you mean the mural thrombus that's laid down within the first week or 2, and it's identified on an early ultrasound. You'll see just a layering of thrombus within the stent. I've done the same as you. I've changed from an antiplatelet agent to actually a Pixaban, 5 milligrams twice a day for 3 months. And I found that sorted it out. But because I think from my experience is that once you see it, it doesn't tend to go away. Well, I mean, do you guys find that problem as well with mural thrombus lining stents post-implantation if you're not on anticoagulants?
After you, Laurencia.
I think every patient gets some in-stent thickening. That's part of incorporating the stent. It's something that actually you want to happen as well, because I think that protects the stent long term. But since I started that routine, I don't see more than a couple of millimeters of that, and I have not until now had to intervene very often to sort that out, but I follow it up closely. I have had patients that had very clear stents, so the kid can hardly see anything. And I still don't understand why, because I have that, for example, in patients that are elderly and they're not moving much. And then I have patients that are young and active, and they do get a thicker thing inside the stent, and I have no clue why that happens. Maybe Gerry will know better. But I do follow it, and I do believe that if it becomes significant, and again, that's debatable what's significant, we need to treat it, because I think once it gets organized, then it's way more difficult to treat. You know, you have that soft part that if you balloon it, it goes away, and then you have that hard rubbery stuff that no matter how hard you balloon, it does not go away.
Yeah, I'm inclined to agree with Laurencia. In-stent restenosis, I remember the first time it happened to me, I asked Peter Negland, who used to work with Raju in Mississippi, and I said, what do you do? And he said, well, there's two types. There's one is soft, and you balloon it, and it's really easy. And I said, okay, and the other one? He said, it's hard, it's rubbery, and nothing I can do makes it any better. And I'm afraid to say that that is 15, 18 years ago now, and it really hasn't changed much. But, pardon me. Laurencia is right for a start. I suppose the first thing is that in-stent restenosis in veins post-stenting is, it's not the same pathological or pathophysiological process as you get in arteries. So it's not a neo-intimal hyperplasia, and therefore drug-eluting balloons have, at least in my experience, no place as yet. What it seems to be is just thrombus, bland thrombus. And I've biopsied plenty of them, and I've sent them away to all the great and the good, and I've never come up with anything at all. So I think Laurencia is again correct. And by the way, that was a really good presentation, Laurencia, and actually you've given most of my presentation, so that'll make mine much easier. I've spent most of my time deleting most of the slides. And there's a whole load I want to actually talk about, or rather touch on, in terms of your presentation, because you hit so many good points. But coming back to in-stent restenosis, I agree that you should balloon it aggressively earlier rather than later. I don't know why my young, fit triathlete patients get more of it than my older sedentary patients. I don't understand that. I suspect part of it is that the triathlete patients, call them what you want, are much more symptomatic, or rather, because they stress their venous systems, they're much more symptomatic. Like one of them, for instance, says, things are going great. You know, I can run 28 minutes at 2% on the treadmill, and I'm thinking, God, I could barely drive that far. And she said, and I have no venous claudication. But then she'll tell me straight away, oh, it's back, because yesterday I only ran 17 minutes and I was at 1% and my leg is hurting. So we need to schedule an appointment for 6 weeks. And I'm like, okay, but you're never going to hear that from an 85-year-old. You know, I mean, these are relatively high performance athletes. And so they're much more attuned to their bodies. And old patients, frankly, aren't that bothered, really, you know, to a large extent. But I think that most people have moved into more anticoagulation post-implantation for NIVLs. There was a trend, and a good friend of mine from Connecticut, Peter Pappas, he's from New Jersey, he published a paper a while back where he put in 336 NIVL stents on no anticoagulation and no antiplatelet at all. And he said he had no rethrombosis. And I was like, wow, okay. I don't think that is standard practice now. I think most people nowadays are going for a minimum of antiplatelets, and probably more in terms of low molecular weight heparin for a couple of weeks, followed by anticoagulation. And so that brings me back to Laurencia's like tour de force, really, because probably the biggest take-home message that people should get from your talk, which was excellent, was that patients read a lot on the internet. They've read about May Turner. They've read about, they think they have Nutcracker. They think they have this. They think they have that. You know, they come into you and they've got like a wodge of internet material, and they'll email it to you in advance, hoping that you're going to read it. Like, yeah, not likely. And so half of your business is actually to put them off, you know, and that's so different to most of the patients. Again, with the ulcer patients, it's a no-brainer. You know, patients like that, you do everything for. And I think you're absolutely right. We need to investigate them much more aggressively early. So whether it's a CTV or an MRV, your patient, incidentally, the very first patient, the ulcer patient, they had a total hip replacement as well. And that's something I wanted to touch on, because I found that more and more that these patients end up with a pseudotumor. The orthopedic surgeons recognize it. They say, oh, yeah, it's a pseudotumor. And I assumed it would be this soft, sort of squidgy stuff. It is really high pressure stuff. In fact, to the extent that I saw this mass around a total hip replacement, and the vein was squished down to 2 millimeters and like paper thin, like just like the worst NIVL ever at the level of the hip replacement. And I thought, well, I presume if I just drain the little cyst in my own little sad mind adjacent to the total hip replacement, it'll all go away. So I go in and put my needle in, and nothing comes out. And then I think, that's a bit surprising. So I biopsy it, and it's like the same stuff almost that's inside the stent. It's rubbery crapola, and it will crush the veins, absolutely crush the veins. And to the extent that I've had veins, it's the only time I've had a stent migrate, not into the heart for a change, but like a couple of centimeters north. I put a wall stent in, and I didn't have it quite long enough. And the high pressure from the I'm calling it the hip implantation pseudotumor, squeezed the stent north. And so I was able to bracket it with a Venovo and cover the whole lot in. But they're very, very high pressure. So I suspect that had something to do with your patient's ulceration as well. Even though I'm sure they had their ulceration for 30 years, which was far longer than they had their hip replacement, you know? So,
thank you.
Go on.
Sorry to interrupt there, because I'm very keen to see your talk next, Gerry.
I wouldn't be.
And
it's crap.
Just of time.
Okay.
I'm gonna interrupt, Jonathan, if that's okay, just for 2 seconds, because one thing that Valencia and Gerry both touched on, which I think is very important, is actually the size of stenting. And Valencia said, Laurencia sort of really well pointed out that nowadays we're stenting smaller, 14 to 16 usually, rather than the 18 to 20. And I think the other thing they both pointed out was the in-stent restenosis and the laying of thrombus, and then that fibrosis of it. What seems to be the case, at least in my limited experience, is that the stents I put in which are bigger are the ones which may end up with more thrombus and laying of problems in them.
Yeah.
And I think it comes back to a point that these are capacitant vessels. And if you put this big stent in there and then you don't do much to it, so you don't have much flow, all it can do is have accumulation of thrombus in the layers. Whereas it's supposed to be able to be small most of the time and then adapt big if it can, which we change when we stent it. So that changes everything. But that big open stent, which is too big in some ways, is the one which often really runs into trouble. Sorry.
I agree. Yeah.
And there's one more point I wanted to make, and then we'll go on to my really crap presentation. On Laurencia's talk, okay, the first thing is that when you're warning your patients what to expect afterwards, warning them about anticoagulation is really important, because a lot of them, as you say, want a quick fix. They want, like, you know, we're in the Instagram generation, you know, if people have an attention span of more than 2 seconds, there's something wrong with them, you know. So they expect to come in, have a day case procedure, have a stent, go home, and then start jogging a marathon, and they want their legs to look like, I don't know, Eva Herzegovina or Giselle Bundchen or whatever, you know. And a lot of the patients that come to me, they say, look at my left leg, it's enormous, because I've got a May Turner, because it was picked up on a CTV or an MRV or whatever. And how can we say this politely? Well, both legs might be suffering from the same problem, which is called adipose tissue. And I'm sure it's a problem that affects Australians and New Zealanders as well as it does in Ireland, because it's a difficult one to say, like, basically, honey, you're fat, okay? And I'm not very good at saying it, and I'm sure there's better ways of handling it. But essentially, I think, no, all jokes aside, you got to be very careful stenting patients like this, because they will blame you bitterly for not getting skinnier, their legs not improving, and they have back pain. So I think the point of it is that by putting them on a waiting list for 12 months and making them aware of all the things that they have to do if they're going to succeed, it puts off a certain proportion. And that is actually important, because you want to be treating the ulcer end of the spectrum, the venous claudication end of the spectrum, way more than the swollen legs, in my view. And the final point I wanted to make about your talk is that I'm going to get there eventually. Oh, yes. So when you have the patients on anticoagulation afterwards, you need to have them on, in my opinion at least, a low molecular weight heparin for the first 2 weeks. One, it's anti-inflammatory, but two, you can put them on a non-steroidal for those 2 weeks. And that's kind of key, because if you start them straight away on warfarin, then you can't use diphene for the first 2 weeks, or whatever your non-steroidal of choice is. So I think it's important to have them well warned, to almost put them off the procedure, as you eloquently demonstrated, and then make them aware of the anticoagulation regimen that they must follow. And with that, I'll move on to...
just one more thing. There was one question which, really quickly, to get it right, if you get that hard, rubbery in-stent restenosis and you've ballooned it and it doesn't go away, there's not much you can do about it. That's correct?
Go back at it and do it again.
Yeah.
Nah. I did have one amazing patient, and I bitterly regret not getting her name. Or rather, it was the name of an interventional radiologist who came up to me after a session in Link about 3 years ago. She had a patient with, and I'll be brief, in-stent restenosis. The patient herself was an anesthetist. The patient had venous claudication when she was exercising. When the patient herself took her own INR from the 2.5, 3.5 level to 3.5, she actually got it steady at 4.7. My hematologist colleagues were completely freaking out when they heard this one. The in-stent restenosis disappeared. So, and anecdotally, what I have seen is if I have patients who have developed a degree of in-stent restenosis, if I start them on aspirin as well, the in-stent restenosis, or at least the symptoms relating to it, seem to improve. I don't know, there's a paper in that for somebody who could be bothered, but not me.
All right, you better kick on with your talk.
Okay, boss.
Thank you very much, everybody. So for the audience's benefit, I'd like to introduce Dr. Gerry O'Sullivan. As you're probably aware, it's morning in Ireland and he's definitely had his coffee. So Dr. Gerry O'Sullivan originally trained at St. George's Hospital in London before going on to Stanford, California to learn more about aortic dissection and stent grafting. It was his subsequent discovery of the world of deep venous pathology and its treatment which grabbed his passion and fascination. And our team at the Sunshine Coast University Hospital would definitely like to express our gratitude for the expertise he's shared with us over several complex venous cases. So thank you once again, Dr. Gerry O'Sullivan, and please take it away.
Thank you very much. I will attempt to share my screen now. And there we go. We'll get off the websites which are unsuitable for family viewing. Good. Okay, moving on. Okay. And then down the bottom, this little bad boy here. So this is after the glory of Laurencia's talks and the education of Stevenson and Phillips. We're now going to go way downtown, folks, for a very, very basic talk. And in fact, most of it's already been covered by Laurencia. So first of all, what are NIVL lesions? Well, they're non-thrombotic iliac vein lesions, and most of us originally thought of these as May-Turners, i.e. compression of the left common iliac vein by the overriding right common iliac artery. Raju from River Oaks, Mississippi, was the first person to really use intravascular ultrasound in the venous sphere. And he demonstrated really well that there weren't just May-Turner lesions, but there were lots of external iliac lesions, right external iliac, left external iliac, right common iliac vein lesions. Now to the cynic, you might say, well, aren't we just finding more lesions that we put stents in? Doesn't this suit the companies, or doesn't it suit the doctors who are going to make a fortune off it? That's where the judgment comes in. You will find lesions galore with intravascular ultrasound, or with CTV, or even with MRV particularly, because it tends to overcall lesions. But the trick is identifying those patients who will benefit from treatment. And when you think about NIVL lesions, obviously they're shorter, the inflow is better, there's no reason for them to have an IVC filter, and therefore, and because they've never developed a DVT, there's really no reason for them to be prothrombotic, whereas PTS are the opposite end of the spectrum. And I would have to say over the years, I've treated very, very few NIVLs. I've treated NIVLs which have caused acute DVT. I've treated NIVLs, but I suppose, I mean, that's a poorly phrased. I've treated lesions which have caused an acute DVT, but they cause thrombosis, and therefore they're not NIVLs. But you'll see lots and lots of lesions out there whether it's on CTV, MRV, or ultrasound, or intravascular ultrasound particularly. And you need to decide in your own mind which patients are going to benefit most from treatment. And so for me, I've moved more and more into the ulcer sphere now, and I found that these are the patients who really benefit most. Typically, there's another reason for them to have a lesion, such as the case that Laurencia beautifully demonstrated with the NIVL lesion plus this probably a pseudotumor, because I think on the venogram she showed there was a bit of a curvilinear, what looked like an extrinsic compression at the level of the hip as well. So you often have an additive thing in that situation. And so really you compare these two cases, and it's not exactly surprising that the NIVL patients are going to have a much better outcome than those with post-thrombotic. This is one we did recently in Galway, and he's got prostate brachytherapy Cs, which I'm not sure if you can appreciate here. There's a stoma just about visible here, so he had a combination of colon cancer and prostate cancer and radiotherapy for both. And so he's got lots and lots of reasons to have poor inflow, and in fact his inflow below that was disastrous. And so of course the patency is going to be different between the two. So if you look at the trials of whom data has been released, you had the Virtus was the first out by Veneti Vici, who've subsequently been taken over by Boston. Vernacular from Bard, who've subsequently been taken over by Becton Dickinson, and Abre from Medtronic, who haven't been taken over by anybody yet because they're too busy taking over everybody else. So these are FDA trials. They were typically around 200 patients each. The FDA were very fair. They mandated that at least a third of the patients, or at least, sorry, half the patients had to be post-thrombotic. And in fact, in a couple of the trials, there was slightly more than that. There were 2/3 post-thrombotic. So you can't just have what I would call NIVL chip shots the whole time. I would think it's fair to say that the type of patients that are treated in Australasia and probably Ireland and the UK and Europe is different to those treated to an extent in the United States. And I think that, well, all I can do is show you the numbers. And I know that in one state in the United States, the incidence of iliac vein stenting excuse me, went up 1,100% between 2017 and 2019, okay? So that is not due to a fantastic increase in venous surveillance. It is due to the fact that IVUS got reimbursed and they were able to identify millions more patients, or many, many more patients, and all of those patients got stented. Now, the proportion of those who had ulcers, the proportion of those who were post-thrombotic would be far, far fewer than those who had NIVL lesions. So the NIVL lesions that Laurencia showed, they're what I would call real NIVLs. And by that I mean these are NIVL patients with good going symptoms, ulceration, venous claudication, or significant limb circumference difference. And they're the patients who are going to benefit. But be that as it may, whatever the trial results, and this is why it's a particularly short trial, because the results are essentially the same in all three trials. The patency for NIVLs at 2 years was greater than 96%. In fact, it was close to 100% in a couple of the trials. And I'm deliberately not mentioning which is which, because I think that, well, for instance, in one of the trials, if you had a DVT in the calf, and yet you were subsequently diagnosed as having an iliac vein lesion, they were regarded as post-thrombotic. Well, that's not really post-thrombotic in my book. Post-thrombotic for me means the segment that was involved. So I would have a slight issue with that, but be that as it may, the results were all very comparable for the NIVL patients, and they were well over 96%. In the post-thrombotic syndrome patients, they were much, much lower. Not disastrously low. The benchmark, according to the Rizavi paper in Circulation 2015, would have been around 75%. So the patency of the patients was fine in the trials. And I thought it was real world, because Raju and Neglan, from their large papers, at 5 years, your patency was around 60%. Now, that would be with very old wall stents. Okay. I said, this is from Rob Luxstein's paper, the non-thrombotic 2-year primary patency rate of 96.4%. And in the same thing, this is from the vernacular results. And you can see that the NIVLs are at the top. And if you draw across there, I think it was 96.2% or something like that. And the post-thrombotics, there's a significant spread of nearly 20 points between the two, not quite 20 points, about 16% between the two. So it's fair to say that NIVL patients are likely to stay open. The anticoagulation issue is really interesting. I think most of us starting off would have been, we'll try them with a bit of aspirin. All you need really is one instant rethrombosis and a symptomatic patient. And you've transformed somebody with, say for the sake of argument, limb swelling into somebody with a, not necessarily a phlegmasia, but a severely swollen leg who's now got a risk of not only a DVT, but also a pulmonary embolus. All you need is one of those. And all of a sudden you kind of go, I think next time we might go a little bit heavier on the anticoagulation. And I think the key about anticoagulation in these patients is that it only matters for a number of weeks, because as Laurencia and Stephen and Philip have already mentioned, these patients are prothrombotic, particularly for the first few weeks. And in that time, in that time, they're laying down cells on the inside of the stent. And once that layer of endothelium is in, they're much less prothrombotic, but they're very prothrombotic for the first few weeks. So I think most people would have people on low molecular weight heparin for the first couple of weeks. Some people go straight to NOACs. We could talk about that another day, but unless you trust your patients very implicitly, you've got to be sure whether they're actually taking their NOACs. Whereas if you have them on warfarin, you can check whether they're taking their warfarin, because if they come in, say, with the stent thrombosis and their INR is 1.1, you know damn well they haven't been taken yet. Much harder to check I know you can check antithrombin 10A factor or whatever, but it's very expensive in Ireland. We're not really allowed to do it very much. So I guess the biggest question overall is which NIVL patients will benefit the most. And I think that's why Laurencia's talk was so excellent, because it showed that if you concentrate on the heavier end of the spectrum, the ulcer patients, the claudicants, those with limb circumference difference, as opposed to the younger patients with slight swelling of their puffiness of their ankles at the end of the evening, I think you're going to do better. Just to throw one fly in the ointment, a good friend of mine, when I worked after Chicago, I went to Rush Presbyterian in Chicago. Sorry, after Stanford, I went to Chicago. And Stephen Smith is a really, really interesting guy. He's an interventional radiologist, and these are a group of cardiologists, radiologists, and surgeons between the Mayo Clinic in Scottsdale and Hinsdale, Illinois, just outside Chicago. Essentially, there's a subgroup of patients with iliac vein compression or iliac venous lesions who have really weird symptoms. Just stuff that I find it really difficult to put my finger on it, and clearly a lot of other doctors do. And so these patients, say in the patients that Laurencia was mentioning, these patients have postcoital pain, or they've got dyspareunia, or they've got, they can have blood in their urine on occasion, or they can have all sorts of weird symptoms. Some of them have migraines. Some of them have pudendal pain. They've been to see psychiatrists, pain specialists, everybody. Nobody has a clue what to do with them. And so we're aware that this group is out there, but nobody's really put it all together before. So Steve Smith is a bit of an alternative thinker. And he's had a couple of patients, in fact, 6 in total, he's going to publish shortly, with intractable migraine, who happen to have left common iliac vein lesions on CTV. And they also had, one of them had an ulcer, and I think the rest of them had fairly minor stuff in terms of like leg swelling and so on. He treated them by placing stents, anticoagulation and so on. The migraine specialist in the Chicago suburbs, Chicago's a big place, about 6 million people. So when people specialize there, they really specialize. And this neurologist rang him up about a month later and said, what have you been doing to these people? For the first time in years, their migraine has disappeared. Okay? Now, how the hell is migraine related to iliac vein compression? Nobody knows. But the Mayo Clinic in Scottsdale has got this POTS, as the Mayo Clinic would have to do. They've got a method of measuring different physiological parameters by putting people on tilt tables and so on and so forth. And so that's where this paper came out of. So it is very interesting if you get a chance to read it. It's in Phlebology. And so all I would say is that I think we're actually at the tip of the iceberg of NIVLs. We've identified the anatomy. We've got good methods of seeing it with CTV, MRV, and IVUS. We've stented a subsection. Some of them improve massively. Some of them don't really improve much at all. but I suspect it may tie in with a whole other area in terms of improving venous return. And I think this is going to be an interesting area for the next 10 or 15 years. And that is all. Thank you very much.
Thank you very much, Dr. O'Sullivan. That was excellent. Fascinating. I saw one of the slides for the NIVLs, 96% compared to the post-thrombotic syndrome, 80%. Was that referring to stent patency, and why do you think that is?
Sorry, you're quite correct. Yes, it is stent patency. Yeah, it's stent patency by ultrasound images sent to a core lab at 2 years. So that would be my own experience. I mean, I think I've had one NIVL patient rethrombose, but they had been on a plane or something, you know. And I would say Laurencia and the rest of your colleagues are the same. NIVL patients tend to do very, very well in terms of patency. The issue with NIVL patients is whether you've hit the nail on the head, whether the lesion you treat is going to be responsible for their symptoms. I think that's, at least you tell me, Laurencia, is that how you see it, or? You're mute, Laurencia.
Absolutely, I think, sorry. I think, absolutely, I think they mostly do really well. And the trick is to find which ones are going to benefit. And what you brought up, is exactly what I've seen. The variety of symptoms that are not described anywhere or very few places. And you get surprised. Like I remember a patient came to me after I stented her for leg issues, and she rocked up in my room and she goes, "What have you done?" And I went, "Oh, I don't know, like what happened?" And she's like, exactly. And then she goes, "You know, I've been on IBS medication for 30 years and now I can't take it because I have to go to the bathroom every 2 hours." And so, and I was like, okay, is that a good thing or a bad thing? And then another patient that after I stented her for chronic pelvic pain came to me and said, "For 10 years, I've had to drive with a donut under my buttocks because I was told that I had a bursitis. And now I don't need it anymore. The pain's gone." Bizarre things that I've learned along the way. And so I think you're absolutely correct. There's just so much that we do not understand. So I agree. The only thing I've seen in some NIVL patients that had a pristine ultrasound and then something happened, like I had a little old lady that got a really bad pneumonia, was on like triple antibiotics and things like that, and then she did get a bit of in-stent thrombosis. And again, same thing, I just put her on anticoagulation for a short time and it disappeared, cleared. So I've had a couple of those. So I don't freak out anymore when I see it. I do it, you know, something to that. I leave them all antiplatelets regardless. And then if I have to, then a short-term anticoagulation, and most of them clear very nicely, very quickly. But yeah, I agree. The results are really, really good. That's not the problem.
It's very interesting when you talk about the weird symptoms. A friend of mine in Guildford in Surrey in the UK, a guy by the name of Tony Lopez, has done nearly 3,000 pelvic vein embolizations. And so I went to him about 8 or 9 years ago because I didn't even know really what pelvic vein embolization was. I'd been referred a few patients over the years. I didn't feel very comfortable. Anyway, I saw Tony do 3 or 4 cases and I thought I can probably manage that. I soon realized I couldn't do it nearly as well as him, and he made it like a lot of masters, made it look ridiculously easy. And so I go back and then flounder around, because he had done, I think, 4 cases in the morning, probably stopped for a game of bridge in the midtime. And I was like 4 hours later, still trying to get into the goddamn bin. I thought, I'm never doing one of these again. So I flew back to him, he's near Heathrow, and I said, okay, like, let's just do 1 case for the morning here. Take your goddamn time. And so he showed me the ins and outs, and I got a bit better at it. But anyway, when we're chatting, he said that the number of patients with irritable bowel syndrome, with dyspareunia, with rectal varices, with the cushion, the roundy cushion they sit on, like I have things that I never even heard of, you know? And he said they came back, and he said his only regret is that he didn't publish it kind of in a more prospective manner. He reckoned about 1/3 of patients that he saw had been to see a psychiatrist. 1/3, you know? That kind of got my attention, because You see, it's so easy in men. I treat a lot of arc seals, you know, and like most things in men, it's, you know, it's obvious. Like you've got a big vein, it's outside, it's on the scrotum. The guy gets pain when he, after exercise or after sex. It's really easy. We treat it, we embolize it, it goes away. Happy days, right? Fine. Women, it's, you know, sorry, nothing personal, Laurencia, but Jesus Christ, you guys complicate it. I mean, it's inside for a start, okay? You can't see it. There's no good imaging technique. And the symptoms are much more subtle, and kind of diffuse. And then they get worse at the time of periods as well. And you just, it's very difficult to figure the whole damn thing out. So I do believe the NIVLs, there's a whole game to play. I think we're at a very early stage, funnily enough, of the whole business. And I think the findings we're going to get over the next 10 or 15 years will really change things. I suspect it hard to believe, but I think it'll probably be a bigger area in 10 years' time than post-thrombotic. I really believe
that. Sorry, I'd now like to introduce a question that's been proposed to me via email, and it's really open to the whole panel, but they're wanting to know what is recommended when the post-thrombotic disease extends a long way down the femoral vein.
No, don't all jump at it. Come on, I know you want to jump in that because it's such a fun question to answer. No, hold yourselves back. No, don't do it. Don't do it. Okay, I'll get it over with because it's. I'll give you my tuppence worth. I think the key is, first of all, you need to identify the fact that there is post-thrombotic disease involving the femoral or the profunda. If for those of you new to the venous stenting world, if you have an iliac, say an iliac arterial lesion, and you've got a palpable common femoral artery pulse, you know, you'll puncture it, put in a small 6 French sheath, balloon it, stent it, use a star close or per close on the way out. Everybody's a hero. You can feel a pulse in the groin. Boom, done. You can feel a pulse in the foot. You do that in a post-thrombotic venous case, and I know this because I did it in my first 10 cases. Not only will you screw the pooch, but you'll also screw the inflow, you screw the outflow, you do everything wrong. So whatever you do, don't puncture the common femoral. As the question correctly elucidates, the thrombus and the disease process, when you think of the DVTs you see on imaging, they often involve the iliacs, but they also involve the common femoral, and then they go down further into the femoral profunda. Over time, one of those veins will become less damaged or will be less involved, and I call that the dominant vein. So I think you need to spend a bit of time identifying which is the dominant inflow. And if you use IVUS, you can go from the neck and identify whether the femoral or the profunda is dominant. On occasion, I've even stented into the greater saphenous, believe it or not, if both femoral and profunda were catastrophically damaged. Once you identify which vein is dominant, I would prefer to use a cutting balloon or balloon angioplasty at the ostium and stent as little into the offending or into the dominant vein as possible. But sometimes you've got to go down a few centimeters. And I think my longest one that has stayed open has been about mid-thigh. There's a nice paper in CVIR from the guys in Grenoble in France. If you're ever skiing, that's you'll end up there if you get airlifted. And they've got lots of patients open with stents all the way down to the popliteal, but they're exceptional. They're real masters in their art. So I think identifying the dominant vein is the first thing. Balloon angioplasty or maybe stent into the ostium of it. And you have to go from, I hate to say normal to normal because there's not much normal in these areas, but the least abnormal back to the IVC. And that's done. I'll leave it there.
Fantastic. Thank you very much.
No, that's really a good point, because that brings us back to the IVUS talk, because you can't really assess relatively normal or good vessel to good vessel unless you can investigate from inside the vessel. And IVUS is the only way that you're going to do that.
I agree. Yeah.
All right. We should wrap up there, Jonathan.
No problem at all. Thank you very much, everybody. So I'd just like to draw attention to the audience that we will be reconvening 2 seconds. So we'll be reconvening in a few weeks for session 2, and registration is now open. So that's being held on the 2nd of September. The faculty for session 2 includes a local hematologist, Dr. Scott Dunkley, a local IR, Dr. Chris Rogan, and myself. Another international guest is appearing, and that will be Dr. Stephen Black from the UK. Now, I'm going to show you a QR code on the next screen, which you can use your phone camera for to direct you to the registration page. So here's the QR code. Please take your time to register. And finally, I would like to thank the audience for your attendance and participation in this forum, and also to Bard and Phillips for providing us with this virtual platform. I think everybody will agree that this has been highly educational, and we've had some exceptional presentations. And as always, I find the Q&A and discussion is certainly very informative. So finally, thanks again to our speakers, Associate Professor Laurencia Villabla, Dr. Phil Puckridge, Dr. Gerry O'Sullivan, and a special thanks to our organizer and presenter, Dr. Steve Dubenec.
Thanks, guys. Really enjoyed it.
Thank you.
Thank you.
Thank you.
Tell me